Hello, everybody. I am Alexa Tinsley. I'm the Director of Programs here at Jett Foundation. I want to welcome you today to our webinar series on cardiac devices. Thank you so much for being here. We're going to give it another minute for everybody to hop in here. But in the meantime, if you are comfortable and willing, please go ahead and put your name and where you're located and either you or your child's age in the chat. That would be wonderful. And we will be back in just a moment. All right, perfect. I'll go ahead and get started. Again, I'm Alexa Tinsley. I'm the Director of Programs here at Jett Foundation. I want to thank you all again for joining us today on our webinar series to learn more about cardiac devices. I cannot wait for you to hear from Dr. Andreas Barth as he's going to share his knowledge and expertise with us today. Dr. Barth is an assistant professor in the Division of Cardiology at the Johns Hopkins School of Medicine and director of Center for Inherited Heart Diseases. His clinical work focuses on clinical cardiac electrophysiology with a specific focus on inherited arrhythmia syndromes and channelopathies. So before we get started, I do just want to mention a few things. These webinars are recorded, so they will be live in our YouTube and on Facebook after this event. So if for any reason you know of anybody that was not able to attend or you want to watch it back later, please know that that'll be there, living there in the next day or two on our YouTube, and will be immediately available on Facebook after this event. Also, we will be asking questions at the end. We'll do a live Q&A. I do ask that there's a Q&A box. It's at the bottom, kind of middle right of my screen. It has a question mark in the middle of a box. We do ask that you primarily use those for your questions. We do try to monitor the chat to find questions in there. We also do try to monitor Facebook, but we will primarily be using that panel to answer questions. So if you do have any throughout the presentation, please feel free to put them in there. We do also have closed captioning available. There is a CC box at the bottom right hand of your screen as well. And you can use that and should be able to translate hopefully into the language of your choice. So with that, that is going to be all from me. Oh, if you are watching this later as well, please know that you can ask questions. So as you're watching this presentation, if you are watching the recording, please take notes and we'll tell you how to send questions later on in the presentation. So that is all from me, and I will hand it off to Dr. Barth.
Thank you very much, Alexa, and thank you to the entire team at the Jett Foundation for everything that you're doing. And it's really my pleasure to discuss this afternoon about cardiac devices and how they fit into the therapy landscape for patients with Duchenne, with Becker, and for female carriers. And so you've heard that I'm a cardiologist. Primarily, I'm a cardiac electrophysiologist, so one of the heart rhythm doctors. And I see patients with a whole variety of neuromuscular diseases. And it started off with particularly patients with myotonic dystrophy, as they develop primarily electrical problems with their heart muscle, but it expanded over the last several years to see many patients with Duchenne, with Becker, and female carriers. And as cardiologists, we tend to live sort of in silos. And many patients with Duchenne and Becker are taken care of by either pediatric cardiologists or by patients who are primarily focused on the heart failure aspect. And today I'm going to shift focus a little bit and also discuss how arrhythmias fit into Duchenne and Becker and what to expect in that respect and how devices may help to address that. So let me see whether I can advance the slides here. All right. So the overview of my talk is, before we talk about devices, I want to give a brief overview about heart disease in patients who have dystrophinopathies. And again, that affects Duchenne patients, Becker patients, and also female carriers. And the two large groups are, how does it affect the heart muscle itself? Does it weaken the heart muscle and lead to cardiomyopathy? And the second part is, how does it affect the electrical system of the heart? And we'll talk about how we can monitor that, so diagnose that, and then how can we treat it? And when it comes to treatment, we'll discuss the role of cardiac devices specifically. So let's start with the first aspect about heart disease in patients with Duchenopathies. Before we do that, I just want to give a brief overview how the heart works, and just to simplify it, and probably it's an oversimplification, but you can think about the heart as a pump. It's a muscle. It's not the same as skeletal muscle. It's slightly different, but as it is a muscle, every disease that can affect the skeletal muscle can potentially also affect the heart muscle as well. And the pump has 4 different chambers. There are 2 chambers at the top, we call that the right and the left atrium, and 2 main pumping chambers, the left ventricle and the right ventricles. And they wouldn't act as a pump if it wasn't for the electrical system of the heart. And the electrical system of the heart coordinates the pump function. You can imagine that as having a little microprocessor or a biological pacemaker in the heart that gives the heart an impulse every second. And that biological pacemaker is called the sinoatrial node, or DSA node, and it's located in the top right atrium. And that impulse every second, so 60 times per minute, propagates through the right atrium and has to get down to the main pumping chambers that are doing the main work. The problem is that they are, let me see whether I can turn on my pointer over here. I don't know whether you can see that potentially.
I can actually, yeah.
You can, good. So the impulse has to travel from the right atrium to the bottom chambers, to the ventricles. And here are the heart valves, so the electricity cannot travel through there. But there is a wire that's built into the heart. That wire is called the atrioventricular node. And that atrioventricular node then branches out into 2 different separated wires. One is, now with that, I cannot, let me see, I cannot move the slides anymore. Here we go. It's called the right bundle branch and the left bundle branch. So it's a specialized conduction system that's built into the heart, where the electricity propagates very fast from top to bottom and then can excite both chambers at the same time. So it can coordinate the electrical function from top to bottom and left and right, so that all 4 heart chambers are beating at the same time. And the way to look at that is if you listen to classical music. So there's an orchestra, but in order for the orchestra to play music, you need a conductor. And think about the electricity in your heart as the conductor for the orchestra. And you really need both in order to listen to great music. It doesn't help you if you only have the orchestra without a conductor. So if the conductor is very slow or very erratic, the orchestra will not play in a very coordinated fashion. Likewise, you can have the best conductor in the world, but if there is no orchestra, there is no music either. So you really need both. And the heart function requires this close coordination between the electrical and the mechanical activity. So when the orchestra is affected, that's what we call cardiomyopathy. And this is not uncommon in patients who have Duchenne and Becker muscular dystrophy. In fact, most boys who have Duchenne muscular dystrophy, by the time that they see me, and I'm an adult cardiologist, so I see patients who are older, 18 or older, they already have at least very mild forms of dilated cardiomyopathy. The heart will enlarge, it will weaken at later stages of the disease, and it will prevent it from pumping blood efficiently. And ultimately, cardiomyopathy may lead to heart failure. It can present clinically as shortness of breath. You may develop swelling of the lower extremities or inability to lie flat. And cardiomyopathy may also lead at later stages to an abnormal heart rhythm, which we call arrhythmias, and in rare cases also to a cardiac arrest. And it's important to know that cardiomyopathy is not what we call a heart attack classically. So heart attack is if there is a problem with the blood supply of the heart. So if there are 3 blood vessels that supply blood to the heart. If those blood vessels clog up over time because you develop blockages, that can present as what we call a heart attack or myocardial infarction. And this is not classically what we see in Duchenne or in Becker muscular dystrophy. So how do we diagnose that the heart gets weaker? We can do an echocardiogram of the heart, which gives us usually good images and tells us about the pump function. The problem is that most patients with Duchenne will develop scoliosis, so some abnormalities of the skeletal muscle that will make it difficult to see the heart very well. Echoes or ultrasound cannot penetrate through the lung, cannot penetrate through bones. So we have to find this perfect spot, usually between the rib spaces, where the chest wall and the heart are adjacent to each other. And then we can visualize the heart. But at later stages of the disease, we may not get a good window. And the best way to image the heart in Becker or Duchenne muscular dystrophy is a cardiac MRI. The cardiac MRI gives us all the information that the echocardiogram gives us, with one additional aspect that is important. It also allows us to visualize the scar that forms at very early stages of the disease. And we know that if we see scar, but with a normal heart function, it's already very important to treat, to become very aggressive with medical treatment to prevent further scar tissue formation, so we can prevent the heart from getting weak in the first place. So getting echocardiograms early is important because it provides sort of a very early window of opportunity that would otherwise miss if we just look at echocardiograms. With the echo, we may see everything looks good, but if we drill down a little bit deeper with cardiac MRIs and are able to visualize the scar, we can say, yep, there is already early signs of the disease that are present. And it's really very important at that stage to be a little bit more aggressive with our medical management, because we can very positively affect the outcome and prevent the disease from happening. Last, you may have also heard about cardiac CTs that are used to image the heart. They really only play a very minor role in Duchenne and Becker, and we're largely focused on echocardiograms or cardiac MRIs. And here is an image that is shown from about 70 patients with either Becker or with Duchenne muscular dystrophy. And it shows on the x-axis the left ventricular ejection fraction, or EF. The EF is usually between 55 and 60%. So it's important to know that it's not 100% that is normal, but 55 to 60. And if you have an ejection fraction that is above 60%, that is a good thing. The problem is if the ejection fraction drops, sorry, this is scrolling on its own. If the ejection fraction drops and you develop scar tissue, so the scar tissue is shown here on the y-axis. So the more scar you have and the lower your ejection fraction is, that is not a good sign. And we know that this provides very important prognostic information. So patients who have an ejection fraction of greater than 45% will do well. Those are Kaplan-Meier survival curves, and it's actually event-free survival that we say, okay, have you had any hospitalizations for heart failure? Have you had any significant arrhythmias? And if your ejection fraction is greater than 45%, you'll do well. If your ejection fraction is lower, your event rate will be higher. And if we incorporate not only the ejection fraction, but also the scar tissue, we'll get a much more granular view of the future. So here on top are shown patients who have an ejection fraction of greater than 45% and no scar. The blue lines represent an ejection fraction of greater than 45%, but you already have scar tissue. And you can see that the event-free survival drops significantly. And then if you have scar, if you have an ejection fraction less than 45% with scar, the event rate will go up even more. So this is why it's important to prevent scar tissue from forming in the first place, and starting with medical therapy very early on. And we consider these days 4 pillars of heart failure treatment. And it's very important. There are 4 different medications, and they all play a different role. And it's a little bit like if you fight a war and you're only fighting the war with the army, but you're not using your Air Force, you're not using your Navy, you're not using the Space Force. So they all do something different. They attack the enemy from different angles, but in coordination, they're much more effective than every single one of them would be in isolation. And that's the same way I would look at those heart failure medications. So we usually start with either an ACE inhibitor or angiotensin receptor blockers. So it will be either lisinopril or losartan, or the newer ones are called Entresto. That's sort of the lisino or the losartan, if you will, on steroids. They are much more effective. The second group of medications are the beta blockers. They limit the effect of adrenaline that the heart sees. And commonly used medications are metoprolol, bisoprolol, or carvedilol. The third one block the effect of another hormone called aldosterone on the heart muscle. Two typical medications are either spironolactone or eplerenone. And the last medication is a very mild diuretic. Those are medications that are called SGLT2 inhibitors. Those are medications that were initially developed to treat diabetes. And then we found that patients who have diabetes and heart failure, their heart failure really improved. And then we asked, well, can we give those medications also to patients who have heart failure but don't have diabetes? And the answer was yes, those patients also did much, much better. Their heart failure improved. So we're really considering all those four medications when it comes to treatment of heart failure. And if your EF is less than 45%, you should be on as many of those four medications as possible and at maximal tolerated doses. But we know that it's actually important to start some of those medications early before you develop symptoms. And the best example are the ACE inhibitors or lisinopril. The early studies were done with perindopril. So if you start that at the age before 10, and there's even a discussion to say, well, wouldn't there make sense to start them even earlier? And there's no data to support that, but those medications are so well tolerated that I would be very much inclined to start them at a much earlier stage, as soon as kids can take medications. I think it makes sense to take medications like lisinopril or losartan, because we know you can prevent the disease from happening before symptoms develop. Likewise, beta blockers, because they block the effect of adrenaline on the heart, can be very useful if you have a very fast resting heart rate, so what we call sinus tachycardia, or if you have any palpitations, any arrhythmias. Those medications can help. Even if your heart function is not low, I would consider those medications. If you have a little bit of scar, but your heart function is normal, then I would think about eplerenone together with lisinopril, also medications from the first group, because they are known to prevent fibrosis. And the SGLT2 inhibitors are useful if you have diabetes. And we know that most of boys who take corticosteroids, they're much more likely to develop diabetes. So SGLT2 inhibitors may become useful. And then we also, if patients are symptomatic, that they hold on to fluid more, we also pair those four medications together with the loop diuretics to address congestion. And if you are on one of those four pillars, you reduce the risk of death and heart failure hospitalizations by 32%. If you're on two medications, they're much more effective. You reduce it by 44%. If you're on triple therapy, by 55%. And if you add the SGLT2 inhibitors, you get an additional 25% benefit. So there is no doubt that guideline-directed medical heart failure therapy should be really the mainstay for all patients. Now, what if medications alone don't work? And despite those four pillars, and despite being on maximal tolerated doses, the heart failure progresses. Then there is something what we call advanced heart failure therapies. And they are either LVADs, so left ventricular assist devices, or heart transplantation may be an option, particularly for patients with Becker muscular dystrophy. And the goal of these therapies is to improve quality and quantity of life by restoring heart function. And this is what an LVAD would look like. It's a little pump that's implanted inside the body and helps the heart to pump blood. Because the pump needs continuous energy, there is actually a drive line that's exiting through the skin and it's connecting to a battery pack. Or if you're at home, you can plug it in. It sounds like a very aggressive therapy, and it is, This is usually reserved for patients who have severe heart failure. But previously, patients with Duchenne muscular dystrophy were believed not to be candidates for that. However, now we know that these pumps have really improved, that the quality of these pumps has improved dramatically. And I was at a Duchenne meeting last weekend, and they reported that there is currently one patient with Duchenne muscular dystrophy who got a pump implanted 13 years ago, and he has done exceedingly well with that pump. And so it can really prolong your life in a very meaningful way. And that patient hasn't had any severe complications from this LVAD therapy. And if LVADs don't work, then heart transplantation may be an option for very selected patients with Becker muscular dystrophy, or potentially also with early onset Duchenne. So the first cardiac device that I want to point out today is actually not one that corrects arrhythmias, but one that helps with the heart function, and that's this left ventricular assist device. So the second big group would be arrhythmias, and arrhythmias are an abnormal heart rhythm that occurs when the electrical signals that coordinate your heartbeat don't work properly. And they can either make your heart go too fast, we call that tachycardia. They can make your heart go too slow, that's bradycardia, or they can make your heart irregular. Now, it's important to know that with Becker or Duchenne muscular dystrophies, most arrhythmias are too fast, or they can make your heart beat irregularly, but it's very rare that the heart rate will become too slow. So for Becker and Duchenne, a heart rate that is too slow is really basically never a consideration. Now, arrhythmias can originate from the upper chambers of the heart, and we can have arrhythmias like what we call supraventricular tachycardias. Other ones would be atrial fibrillation. Those arrhythmias are not dangerous, but they are not life-threatening, but they can be a nuisance because they can cause a lot of palpitations. We're more concerned with arrhythmias that originate from the bottom chambers of the heart, so from the lower chambers. Those can be potentially the dangerous arrhythmias that can even lead to a cardiac arrest. Those arrhythmias are ventricular tachycardia or ventricular fibrillation, or in short, VT or VF. And how do we screen for arrhythmias? So the first one is we can get an electrocardiogram, and I'm sure that most of you have gotten that in clinic. It's where we get a 10-second recording of your heart rhythm, and we analyze that. And it's very rare that we see any significant changes that really change management. Often in Becker and Duchenne, the ECG or the electrocardiogram will be abnormal, but those changes rarely are of clinical significance. What we can see, and again, this is only a 10-second snapshot, it doesn't tell me whether there are any other arrhythmias that we're just missing. So it's good to have patients wear Holter monitors where we can record the electrical rhythm for days or weeks at a time. And that will help me to give me a better representative image of what your heart rhythm looks like. And if we're not able to capture any arrhythmias with a Holter monitor, we can even implant a loop monitor. So the Holter monitors these days are just patches that you apply to the chest and that you can wear for up to 14 days. The implantable loop monitors are little devices. They look like a USB stick, and we can inject them under the skin. It's minimally invasive. We can do that just with local anesthesia only, can be implanted in a cardiologist's office these days. And they can be paired with your smartphone. And they can communicate via Bluetooth. And if there is an arrhythmia detected, it will push that data over and send it to our clinic, where we have one of our nurses who reviews that data. It will also record the data if it meets some pre-specified criteria. So even if you don't have palpitations, but if we see that your heart rate is either too fast or too slow, it will automatically record and send that data over. And we have found in a large study that we have done with the Department of Defense, where we studied the natural history of arrhythmias in patients with Duchenne muscular dystrophy, I was the PI in that study, and we looked primarily at ventricular arrhythmias. One of the surprising findings of that study was that many patients with Duchenne, at a stage where the ejection fraction was already mildly reduced, they developed actually an arrhythmia from the top chamber of the heart. And that arrhythmia was atrial fibrillation or atrial flutter. And it may lead to heart failure, but also importantly, it may lead to stroke. And this atrial fibrillation is most commonly missed when you just get an ECG or when you even do a Holter monitor, because the episodes may happen every 2 or 3 months. And if you just don't wear a monitor at that time, you may just miss it. So we found that about 10 to 20% of our patients with DMD who are older and have mild to moderate heart failure have atrial arrhythmias. And they're best detected with a loop recorder. And it's important to know, because if you have atrial fibrillation, we need to discuss about starting a blood thinner to minimize the risk of blood clot formation in your heart. Because we know that if you form a blood clot in your heart, little parts can break off, travel with the bloodstream, and the first vessels that take off after the heart go to the brain. And if a blood clot travels to the brain, you're at risk of having a stroke. And importantly, also, this atrial fibrillation can make heart failure worse. So we need to treat that usually with antiarrhythmic drugs. The other big arrhythmias group to consider are arrhythmias that are coming from the bottom chamber of the heart. Those are the ventricular arrhythmias. So ventricular tachycardia, or VT, or ventricular fibrillation, VF. They may lead to palpitations, passing out episodes, and VF usually can lead to sudden cardiac death. The major risk factors for VT-VF are, and I'm recycling the slide that I showed before, is a low ejection fraction and a very high degree of scar tissue in the heart. This is why it's important to be so proactive with medications, to really catch the disease early and to prevent the disease from happening, that hopefully we can push out arrhythmias for many, many years or many, many decades. The other important part that I want to stress is that, yes, it's a disease that affects primarily the skeletal muscle, but we have seen cases, particularly in female carriers or in patients with Becker muscular dystrophy, where they had actually a relatively preserved skeletal muscle function, but they presented with worsening heart failure. So there is not a one-to-one correlation between skeletal muscle weakness and risk of heart failure and arrhythmia. So the other is also true, that you can say, oh, now my skeletal muscle is weak, so my heart automatically has to be affected as well. We know that it's a risk factor, but we really have to do cardiac surveillance in all patients with dystrophinopathies, whether you're Duchenne, whether you're mild Duchenne or Becker, or you're female carriers. So you need to see a cardiologist who is familiar with dystrophinopathies or with cardiac genetic diseases, and who can screen you appropriately. So how do we treat ventricular arrhythmias in patients with Becker and Duchenne muscular dystrophy? Again, the most important part is to manage heart failure with medications. If VT occurs, is add antiarrhythmic drugs, and then potentially consider an ablation. Ablation is a catheter procedure where we're going from the groin through a blood vessel with a catheter. It's a long spaghetti that has an electrode at its tip, and we can measure the electrical activity with far greater precision from inside the heart than what we can do with an ECG from the chest wall. And if we identify a spot where this arrhythmia is coming from, we can cauterize it and prevent it from recurring. Now, as the ablation is, in a rare case, is very seldomly curative, that we can say, okay, we did an ablation or we treat you with antiarrhythmic drug, and now I can guarantee that it won't come back. Unfortunately, I cannot do that. And in order to prevent sudden death, we often implant cardiac defibrillators, or in short, ICDs. And this is where we talk more about cardiac devices. So here you can see a transvenous ICD. So an ICD is a little computer with a battery that's implanted under the skin, usually under the left collarbone, and it's connected to the heart with a wire. That wire we call a lead. It's an insulated wire. That lead is threaded through a vein that runs under the collarbone, and we can advance that lead into the heart and anchor it in the heart. And then we connect it to the defibrillator, And what this defibrillator does, it monitors every single heartbeat that you have. If your heartbeat is normal, the defibrillator won't do anything. It will just sit there and monitor. But if you ever go into a dangerously fast rhythm, and this is a patient with Duchenne, and that is what we call ventricular tachycardia, that defibrillator will be able to detect that, and it will be able to interrupt that tachycardia. It will be able to terminate the tachycardia either by trying to pace you out of it, by pacing slightly faster than the tachycardia. That may work in many cases. If that is not successful, it will be able to give you a shock. So it's what you see in the movies where they put the pellets on the chest and they shock you. This is what the defibrillator can do. And we can pair those defibrillators in rare cases also with a pacemaker. So we can combine, the pacemaker is there for a slow heart rate, the defibrillator is there for a fast heart rate, but we can combine them in one device and give 1, 2, or 3 leads depending on what the needs are. Now, defibrillators are great because they're the most effective protection from sudden cardiac death. It's like having EMS with you in a box. Wouldn't that be great? And why don't we use them widespread for all patients, right? Because unfortunately, every powerful therapy has also complications. There is no free lunch. Everything comes at a cost. And it's an invasive procedure, even though I would consider it's minimally invasive. But if you have Duchenne or Becker, well, you will require anesthesia. And we know that there is a risk of anesthesia-related complications. Even though it seldomly requires general anesthesia, or it almost never requires general anesthesia. And we can do that either with local anesthesia or with what we call twilight anesthesia or moderate sedation to really avoid a breathing tube during that procedure. And it's important to know that if you have a defibrillator, it will not make you feel any better. So I can't tell you we put a defibrillator in and your heart failure improves. This is literally like a life insurance, the defibrillator. If you ever go into a dangerous arrhythmia, it's there to protect you, but it does nothing to improve the heart function in most cases. So unless it's a combined pacemaker defibrillator, there are some cases where that's the case, but for the vast majority of cases, it's really only a shock box to prevent sudden death, which is important. But again, it's not a device that we implant and your quality of life afterward improves dramatically. One thing to consider is that that's unique to the United States, that the labeling of those ICDs by the FDA is not that they are labeled as MRI safe, but the labeling for all devices from all manufacturers is MRI conditional, which means, yes, you can have MRIs, and yes, it will not affect the ICD in any way, but it's mandated that you follow a special cardiac device protocol, which means that there needs to be a technician there or nurse before you have the MRI to deactivate the device. You need to have ECG monitoring during the MRI. And when you come out of the MRI, somebody needs to turn it back on. That requires additional resources, and it's not very attractive for hospitals to do that. And we here at Hopkins, we have a wait list for close to a year if you need an MRI with a pacemaker or defibrillator. So it can make getting an MRI, particularly if you need it for your spine or for other purposes, much more difficult to get. Then the two big complications with defibrillators that are important for you to know is that it's a little computer with a battery. Well, and have you ever seen a computer that malfunctions? I think we all have. And the ICD can be tricked into thinking that there is a dangerous arrhythmia when in fact there is none. And you can get a shock when you in fact don't need one. And we call that an inappropriate ICD shocks. That can be very painful. It's like if you put your finger in a socket and get electrocuted. So that can be very traumatizing for patients. And it's really important to know that everything we do, we have to take that into account. Now, I have to tell you that we as physicians have learned how to program devices to really minimize the risk of inappropriate shocks. So we have made those devices everything but trigger happy. So we really delay shocks as much as possible to really minimize the risk of inappropriate shocks, but it's not zero. And additionally, the devices have gotten much better over the years. and they can discriminate what is important, what is not important, when should I shock, when should I not shock. So that risk has become lower, but it's not zero. And it can be very traumatizing for patients if they have inappropriate ICD shocks. What we ideally want is that you get an ICD shock only if you pass out due to a dangerous life-threatening arrhythmias. And again, at that time, when you passed out, then you wake up after the shock and you don't even realize that you got shocked. But if you get shocked when you're awake, it can be very traumatizing. The second big risk factor is that there is a risk of infection. If we implant a device in you, and it's in the bloodstream with the lead, with this insulated wire, it can make you very, very sick. So it may require, or most certainly will require, not only removal of the pacemaker slash defibrillator, but also of the wire that's implanted into the body. And it's relatively easy to place a wire through a vein into the heart. It's not so easy to remove it after a while, because what happens is that this wire will grow into the blood vessel and it will form scar tissue, and it will be very difficult to remove. And what we have learned is that there are alternative approaches that have been explored. So we're not only placing this defibrillators through a wire that goes into the heart, but we can place a defibrillator that's significantly bigger, and it's not placed under the left collarbone, but it's placed on the side. And we have a wire that comes across under the skin and goes up on top of the breastbone. And it's not in the vasculature, it's not in the blood vessel, which is very elegant, but because it's not touching the heart, the device is a little bit bigger. So it's considerably bigger. It's about twice the size that you have with the defibrillator that's implanted under the left collarbone. But it's very attractive for patients who do not need any pacing. So I think this would be a really good device as an alternative device to the transvenous defibrillators, where the risk of infection is significantly lower. And over the last 1.5 years, there is one more device that has been approved. It's called the extravascular or EV-ICD. It's also implanted on the side, and let me just go back. It has a lead, it has a wire that goes across the breast wall and then goes underneath the sternum, underneath the breastbone. So it's closer to the heart. So the size of the extravascular ICD is smaller compared to the subcutaneous ICD. The image here actually doesn't do it any justice. It's about half the size of the subcutaneous ICD. So that may be a good alternative for some patients who require an ICD but don't need any pacing. So who would need an ICD? What do guidelines recommend? So the latest guideline from 2022 say that if you have Duchenne or Becker, we recommend an ICD if you had a dangerous arrhythmia that was documented, that was sustained, so for more than 30 seconds, or if you had a cardiac arrest and were lucky enough to survive it. Now, I have to say that most patients who have a cardiac arrest, unfortunately, do not survive that. The risk of surviving into hospital discharge are less than 5 to 10%. So it's really important to consider it, well, who would be at higher risk? And those are those patients who have an ejection fraction of less than 35%. So that's not 30% of what's normal, but it's about half of what's normal. Keep in mind, normal is about 55 to 60%. And if you are on guideline-directed medical therapy at maximal tolerated doses for at least 3 to 6 months. If your ejection fraction doesn't improve and it remains less than 35%, and if this is consistent with your goals of care, then a defibrillator certainly is something that would be reasonable to consider. As we don't fully understand who would ultimately benefit from a defibrillator and who doesn't, I just want to advertise one of our studies that we're currently doing, and this is important to better understand the natural history of arrhythmias in patients with Becker, Duchenne, or female carriers who have a cardiac device implanted. If you have a cardiac device implanted, somebody thought that you're at higher risk, and we want to see, well, how many arrhythmias have you had over those times? So what we collect is basic demographic, medications, and we'll look at the ejection fraction. And I would like to know what are the interrogations of the ILR, or so the loop recorder or the ICD show over many years, have you had any dangerous arrhythmia, or was the defibrillator implanted and you actually never had any arrhythmias? That would be important to know. Have you had any complications from device implantations? Any infections, any lead revisions that were necessary? And what we do is, with the cardiac MRI data, we built, together with our biocomputational department, digital twins. So we use, it's like personalized heart models that incorporate the scar tissue that is there. And we know that it's not a yes or no thing, that you say, okay, do you have scar or you don't have scar? If you have scar, it really depends how much scar you have and what the scar geometry looks like. If you have many little islands of scar where you can form electrical short circuits between those islands, that's probably much more dangerous than if you have a very homogeneous large area of scar. So we try to incorporate all that information in a personalized 3D model that has more than 1 million points, and then we put that through a supercomputer, the same computer that the NASA would use to do their calculations. And it takes sometimes more than a day for all those calculations to compute. And then we can see whether that correlates with the amount of arrhythmias that you had. And if so, we hope to improve the risk stratifications for arrhythmias in patients with dystrophinopathies in the future. And if you do have a device and you're interested in participating, please let me know. I will be delighted to discuss with you on a one-to-one basis and how you could contribute. Thank you very much for your attention, and I would be happy to take your questions at this time.
Thank you so much. We definitely have a few questions. So that was super informative. Really appreciate you sharing that information. I think it gives a lot of insight and answers a lot of people's questions, especially the ones that we had before the presentation. So thank you. Our first question is, how do you know when the LVAD is appropriate? So what would the typical left ventricular ejection fraction be? And what are the symptoms in case the doctor's not aggressive enough?
Yeah, so the LVAD is, it's important if your ejection fraction is low. If you have a normal ejection fraction, you would not be a candidate for an LVAD. So the ejection fraction usually is in the range of 20% or less, and you're on all 4 medications, or you reach a point in the disease process where you can't actually even tolerate those medications anymore because your blood pressure keeps dropping. And so your heart function, that's sort of a signal that your pump is getting weaker and weaker and weaker. And we can't support this with medications alone. In that case, I would talk to your cardiologist, and you need to see a special provider who focuses on heart failure, and then to discuss whether you would be a candidate for those left ventricular assist devices. I can tell you that there is a culture shift that occurs at this time. A lot of cardiac surgeons in the past, those are the physicians who implant those left ventricular assist devices, or the LVADs, did not even consider patients with muscular dystrophy to be candidates for LVADs in the past. They thought, oh, you have muscular dystrophy, we really won't consider you at all. There is more and more data from Europe, but also from the United States, that patients with LVADs do really well. And that should not preclude you from getting an LVAD. Now, I can tell you that, or at least it should not be a no from the get-go. You need to go to a specialized center where they're more familiar with muscular dystrophy and with LVAD therapy, and to get a good opinion. But there are probably 5 or 6 centers across the United States who have a lot of experience in neuromuscular disease, where they would consider you. In many centers, they probably still what you hear to this day is no, you wouldn't be a candidate.
Perfect. Thank you. Second question, are antiarrhythmic drugs contraindicated in someone with structural heart disease commonly found in dystrophinopathies?
Yeah, so that's an excellent question. And the answer is no, they're not contraindicated from the beginning. But everything that we do, there is, you know, there is a pro and a con. And the electrical system in the heart um, is a very, is a very delicate balance. If you have arrhythmias, you shift that balance in one direction. So what antiarrhythmic drugs are used for is to restore the balance, the physiological balance that is there. The problem with antiarrhythmic drugs is that they may shift the balance, they may overcorrect, and then you shift the balance in another direction. Um, and that may be what we call pro-arrhythmic. And what your listener was asking is, well, we know that if you have structural heart disease, the risk of pro-arrhythmia is higher. And that is true. But if the antiarrhythmics are prescribed by an electrophysiologist and you're monitored very closely for some of those side effects, or you have a defibrillator, if you have a defibrillator, we're a little bit more liberal what we can accept with respect to risk. Not all antiarrhythmics are off limits from the get-go. There are some antiarrhythmics that are okay to use even with structural heart disease.
Perfect. What if you are in heart failure with preserved EF and on all the appropriate medications and still having frequent episodes of tachycardia and PVCs?
Very good question. In that case, what I would consider is adding antiarrhythmic drugs. If the antiarrhythmic drugs don't help, then consider if you have frequent PVCs or VT, then consider an ablation. So that would be talking to a specialist like myself, who is an electrophysiologist or heart rhythm doctors, whether we can sort of now, we're ready to take it to the next level and say, okay, do we need to do an invasive procedure, even though minimally invasive, coming up with a catheter from the groin and examining the heart in more detail, finding the spot where the arrhythmia may originate. And is this something that, well, what kind of arrhythmia is it in the first place? And B, is it something that is amenable to ablation? But yeah, if you have heart failure with preserved ejection fraction, that may be something to consider.
Perfect. What are the determining factors when evaluating Duchenne patients for advisement for and against proceeding with the implantation of the LVAD? And I think you alluded to this a little bit already in your previous question, but for the person who asked this question, if there is something outside of what was already answered, please go ahead and add it in here. But I do think that was already previously answered.
Yeah. So one thing that I want to say, what are the most important limitations is your lung function. So that is one of the parameters that we'll look at. If you have a relatively preserved lung function, then an LVAD is something that certainly should be considered. And the other aspect is whether you're ambulatory or not. If you develop heart failure at a very early age, where your lung function is still relatively preserved, and you're ambulatory, then I think an LVAD is certainly something, or even the defibrillator or an LVAD is something that should be strongly considered. As you get older and your lung function deteriorates, and you have more contractures, it becomes a little bit, the comfort level of doing LVADs will become a little bit less and less and less and less. That's why it is important that you present to a center that is familiar with neuromuscular disease and LVADs, that you have a team of experts who's not, deterred by, oh, you have from the get-go and says no. It's a very individual decision that is worth considering.
Perfect. And then we talked about this, but someone is asking the question. So since we're on the topic of LVADs, heart transplants, and why we don't necessarily talk about that as an option.
It's because of the, so if you talk about heart transplants specifically, or LVADs, it's unfortunately politics. If you, an LVAD is, surgery, it's not widely available. There are a couple of, centers in the United States, very academic centers, tertiary care centers that offer that, and likewise, when it comes to organ transplant, there's a limited supply of donor hearts. So whoever implants LVADs and whoever implants does a heart transplant needs to prove that their numbers look great, that patients survive after having a heart transplant at a rate that is comparable to to the national standard. And if you implant patients who are very, very sick, and suddenly your survival curves drop significantly compared to the national standard, you may be excluded from getting hearts in the future. So surgeons are very nervous to implant patients that they perceive are higher risk. And this is what the culture change that occurs at this time, that we're getting more and more data that show, no, actually patients with neuromuscular disease, if they're selected carefully, they do as well as if you didn't have neuromuscular disease. In fact, their cardiac support system is so good that they do sometimes even better. And we should not exclude them from the beginning. And the same is true also for organ transplant. So we may see that in the future, that more and more patients actually are candidates for that.
Perfect. On the same topic of LVADs, what if you have heart failure with EF around 20 and are non-ambulatory with a lower degree of lung function? Would an LVAD be recommended? And it sounded like from your answer previous, possibly no, but I'll let you answer that.
Yeah, it's a very individual decision, and it really depends on so many other different factors. So I would urge you to seek advice and go to a center where they do a lot of LVADs in patients with neuromuscular disease. I can tell you the two that stand out right now. It's the Children's Hospital in Cincinnati and UT Southwestern. They have a lot of experience with VADs in patients with neuromuscular disease. So those would be really important centers to consult.
Where would someone find more information on centers that do have more experience outside of those two?
I would talk to your cardiologist and discuss that depending on where you live inside the United States. There may be centers on the West Coast or East Coast that certainly also have a lot of experience.
Perfect. And then last question that I can see, if anybody does have any more questions, please go ahead and put them in the Q&A. I don't see anything in the chat or Facebook either at this time. But if we are using lisinopril and eplerenone, should we also do a beta blocker?
Yeah. So all those medications, you should, if you're on lisinopril, if you're on eplerenone, most patients at that stage will also be at least on a low dose beta blocker.
Perfect. Just checking Facebook. No other questions that I can see. Dr. Barth, thank you so much. I truly, truly appreciate your time and your expertise in sharing this and helping us educate the community. I think this is something that, we've heard a lot of need in the community, learning more. So thank you. Again, if you are watching this after the fact, please feel free to reach out to Dr. Barth. If you don't feel comfortable reaching directly out to him, please reach out to us. You can email me at alexa@jettfoundation.org and we will go ahead and get that question to him. Thank you all for being with us here today. We could not do it without you. These webinars are for you. So if you have any other topics that you would like to see, please feel free to reach out as well. Thank you again for being with us on this Thursday afternoon, and we will see you all very soon. Have a wonderful day. Bye, Dr.
Bye-bye.
Thank you.